This is week 4, video 3, challenges of the uninsured and underinsured and policy approaches to address health disparities. Some of the challenges of the underinsured include high out-of-pocket costs. If they're underinsured, they have high deductibles, lots of co-payments, co-insurance, and this leads to a lot of out-of-pocket expense. This financial burden, even though they have insurance, can limit their ability to use health care services and medications because they just can't afford it. Limited coverage for essential services. Some underinsured plan may have limited coverage for essential health care services. Mainly, preventative care is the big thing I see, along with mental health services. They often will not have any prescription medication coverage. So what happens is people either have to not get necessary care done or ration necessary care due to their coverage limitations. And they also have narrow provider networks. There are a very limited number of suitable primary providers and specialists to help meet the individual's care needs. Delayed or deferred care, when they have so much out of pocket that they have to pay, people will delay getting care, and it can, when you think about something like cancer or heart disease, delaying getting the needed care can cause irreparable harm to your health. It can cause financial strain and medical debt. They may struggle to pay medical bills, and it may cause them not to be able to pay other bills that they may have, and will cost them their well-being. It will make them feel extremely stressed. Inadequate coverage for chronic conditions. We know everything we've talked about so far this week has talked about managing chronic conditions as a way to utilize resources most effectively. But a lot of times they won't have any, in these underinsured individuals. These policies don't have that management of chronic conditions. So it doesn't address them, so they may have to pay more for services because their condition isn't being managed, and they may have suboptimal health outcomes. Limited access to specialist care. These plans may not have specialists. They can this can stop people from getting care that they need. They might have problems getting referrals. There's nobody in the plan that they can go to. We know that when people don't have help with prescription drug coverage, a lot of times they will be choosing between day-to-day needs and medications. So they might pay their children's book bills instead of getting their meds, or, for elderly people, a lot of times it's even, if it comes between feeding their pets and paying for their medication, they will choose their pets. So this is why a lot of people are non-compliant with their medication plan. We always have to think about that. There are barriers to preventative care, because they may require higher out-of-pocket costs, whereas a lot of insurance policies, like my insurance policy, they encourage me to have an annual physical, and I do not get charged for the physical. They do that in the hopes that I will be healthier and not use as many services, and they will not have to pay for as much for me. Medical bankruptcy is something that happens to the underinsured. They become so overwhelming. There are long-term financial consequences. Some employers-sponsored coverage limitations are such that people cannot get the care that they require. They may have insurance, but it's inadequate for what they need. uncertainty and lack of transparency. Sometimes it's very difficult to understand the insurance and potential costs that can happen with underinsured individuals. And there's a lack of transparency. They feel uncertain, and they may either have unexpected expenses or not get the care that they need because they're afraid of getting in trouble financially. How are we addressing challenges of the underinsured? Well, we've tried to enhance the Affordable Care Act. The proposals to enhance the act have been built upon improving access to affordable health coverage, and they were trying to have subsidies for low-income individual, expanding Medicaid in most states, and doing what they can to address gaps. Reducing out-of-pocket costs, capping co-payments, lowering deductibles, limiting cost sharing. These things are something that can be done to help the challenge of the underinsured. Continuing to look at expanding Medicaid. A lot of the people who are underinsured are below the poverty level. So seeing what we can do to expand Medicaid to help cover them, or at least cover the gaps. Public option. There are proposals for creation of a public health insurance option that individuals can choose to buy into. Public option, it would increase competition in the marketplace and bulk people together for purchasing into these plans to make it more affordable and comprehensive. Standardizing health plans, making requirements to ensure that every health plan provides a minimum level of coverage for essential health services. And then putting controls on prescription drug prices and using the collective power of either the insurance companies and or the government, Medicare, Medicaid, to negotiate the best prices and cap price increases. Expanding telehealth. Access to telehealth can improve healthcare accessibility immeasurably, especially to people who are shut in, who have trouble getting out. I know a lot of elderly people who can't make it to the doctor's office. Telehealth helps them manage their illnesses, helps to reduce barriers to their care. Community health center funding, having community health centers that serve as a safety net for underinsured and uninsured population, where people can go to get the care, especially primary care services they need. Transitioning to value-based care models that focus on improving health, reducing costs, and that these incentivize that preventative care and try to reduce unnecessary hospitalization, and that would also benefit the underinsured or the uninsured. Employer-sponsored insurance reform. There are policies that people attempt to put forth to have employer-sponsored insurance plan cover more things, to reform them, trying to get rid of things like high deductible and limited benefits, and try to make efforts to enhance the comprehensiveness of the coverage and decrease the out-of-pockets or financial burdens for employees. And health equity initiatives specifically targeted at addressing health disparities, improving health equity, looking at the disproportionate impact of underinsurance on certain populations. When you're looking at health disparities, certain populations are much more likely to be uninsured or underinsured. And even some of the people above the poverty level, they have insurance for their kids through CHIP, child insurance programs. But sometimes if they are not Medicaid eligible, they're like in that gray area in between, they suffer, and having initiatives for health equity would ensure that they don't fall between the cracks. Education and outreach programs, letting people know about their health insurance options, awareness, literacy about knowing what the plans cover. And I know this is important whenever it's Medicare time. They will have, because Medicare is hard to navigate, they will often have an education push from the Department of Health and Human Services to help educate people and try to push them into those managed Medicare plans, basically, as a lot of that too, because it saves the government money. Provide incentives for employers to offer the most comprehensive health insurance cover possible. That might be tax incentives or other means to make sure that high quality benefits are provided. The Affordable Care Act was an approach to address health disparities, and it definitely deals with, it has provisions to deal with disparities in health and to subsidize health insurance, and to promote community health centers and value-centered care. Medicaid expansion, trying to get more people who are on the verge of needing Medicaid, making sure that they have coverage. The Patient Protection and Affordable Care Act, that's goes along with the Affordable Care Act. That's legislation to further expand access to affordable health care, reduce prescription drug costs, and address health disparities. And community health center funding, trying to, as I mentioned prior, trying to get policies that would increase community health centers where care can be provided at much lower costs. Culturally competent care initiative. We know that if we educate healthcare givers to provide culturally competent healthcare, that there, especially language access for diverse populations and other cultural health related culture that different groups have, that's going to help us to improve their health care. And social determinants of health initiatives, trying to address those social determinants of health, such as housing, education, employment, and food security, making sure that we know that we try to meet those needs so that people can have positive outcomes. And that's kind of, if you remember back in psych, Maslow's hierarchy of needs, you have to meet the basic needs before people can have self-actualization or optimum health, in our case, looking at that. Maternal and child health care initiatives. There are programs that focus on there. We know that even though we are a very wealthy nation, that we are not in the top when it comes to maternal and child health, unfortunately. We want to make sure that we have policies and programs on reducing maternal and infant mortality rates in communities with high rates in the greater Cincinnati area, especially among women of color, especially African American women and newborns. We know that they have a higher than average rate of morbidity and mortality. So that is an area that we especially want to approach in our area. Mental Health Parity and Addiction Equality Act, MHPAEA is the acronym. This is basically legislation that requires health insurance plans to provide mental health and substance abuse disorder care, and in the same way they provide medical and surgical benefits. We know that most plans don't, historically, mental health care was, especially in addiction, was not something people worried about, including in plans. That was for other people, I guess, is the way. They thought there wasn't a lot of people, but we do know we have especially since the pandemic in 2020, there is increasing numbers of people with mental health issues. And we know that substance abuse is a huge problem in our country, and we want to help get people as healthy as possible. Educational equity initiatives. We know that the more educated you are, the more positive health outcomes you have. So trying to have initiatives to improve educational attainment, get people to be getting their degrees, study a profession so that they can be more educated and have greater financial opportunity. And then reduce disparities in the educational resources and success. And that's something we are always looking at here, trying to make sure we're being as equitable as possible. National Partnership for Action to End Health Disparities, NPA. That's a collaborative initiative led by the Office of Minority Help to get people mobilized and to connect individuals, organizations, and communities to work towards eliminating health disparities in the communities. There's partnerships, there's data collection, evidence-based practice, and engagement in the community. And then just health equity reporting and data collection, trying to improve the data that we collect to determine if there are health disparities, to look at outcomes, and so that we can address inequities in healthcare access and outcomes. The Affordable Care Act, looking at some of the success and challenges of some of these things. With the Affordable Care Act, as we talked about in video 1, it's expanded access to health care through the subsidized health plans and the Medicaid expansion. So it's reduced the rate of the uninsured Americans dramatically, and it tries to eliminate certain disparities. Insurance discrimination based on pre-existing conditions is a big one. The challenges are, our challenge now is political, people wanting to get rid of the Affordable Care Act, but disparities also continue. And even though we have seen some movement, it varies depending on demographic and states, the success in reducing those disparities. Some states still have not expanded Medicaid and probably won't be expanding it, Medicaid now, leaving that coverage gap between low income and especially low middle income individuals who are employed or underemployed but don't have adequate insurance. Medicaid expansion, it's been successful where it has taken place. It's increased access for low-income individuals in the states that adopted it. It also has demonstrated improved health outcomes, including that maternal and infant health that we discussed. But not all states have expanded Medicaid, leaving millions without access to affordable health coverage. And the debates around this continue. Community health center funding. The success has been increased funding for community health centers, has increased access to primary care for underserved populations, which leads to positive health outcomes. But funding levels are often insufficient to meet the full demand for services. So we just don't have enough money to provide the level of service that needs. And to we might need more support because when we're in areas, in areas where there is broader issues with social determinants of health. Culturally competent care initiatives, whenever you have culturally competent care where people are being communicated to in their own language, or you're focusing the care on their culture so that you are meeting them where they live, there's going to be increased compliance. Another big thing is diversity in the healthcare workforce is a part of culturally competent care, and we have seen some growth in that area, but there's still disparities persist, and there's a need for ongoing training and awareness to address culturally competent gaps. And I just fear that this is going to be seen as counterintuitive to the desire of the current administration to remove DEI initiatives. This isn't DEI. This is meeting people culturally where they're at to help them become as healthy as possible. Social determinants of health initiatives. Recognizing social determinants of health has just led to increased awareness, and we've seen a lot of collaborations across sectors. People are addressing housing, education, employment, and not just focusing on health, although we, of course, do focusing on health, but to see that health lies in a larger context with people, and people with deficits are not going to be able to achieve maximum health. The thing about social determinants of health is it requires sustained interventions. It's a slow road to get the funding that you need, and the initiatives are political in nature. To getting the funding is political in nature. So when you swing towards groups that don't believe social determinants of health are important, there's going to be less funding to help deal with social determinants of health. Maternal child health initiatives, it's improved some outcomes, but there are still disparities in care. Racial disparities, particularly in maternal mortality and infant mortality, are something that continue to be addressed and studied because these remain an issue, even though there has been some movement. The maternal mortality rates for Black women is still a huge need for us to address. We need to have more comprehensive, targeted, and might I say culturally competent efforts to address improving outcomes for this population. Mental Health Parity and Addiction Equity Act. The positive has been its improved mental health services. Those parity requirements that say you have to have not only medical coverage, but mental health coverage in plans has been positive, but there still is a stigma surrounding mental health and addiction. There are shortages of workforce, individuals who work with this population, and enforcement when it comes to this act, and I don't feel that it's going to be enforced closely in the future, still limits access to care, mental health care. Educational equity initiatives, there's still disparities in educational resource and opportunity, which will contribute to ongoing health disparities, but we have linked education to better health outcomes, so that is a success. And the National Partnership for Action to End Health Disparities, NPA. This group has fostered collaboration and community engagement, raised awareness of health disparities, but sustained efforts are needed, and the impact varies across communities, and change is slow and incremental, and people sometimes give up before a positive outcome can be attained. Health equity reporting and data collection. The improvements in data collection and sharing data in an appropriate manner, not sharing it where we shouldn't be looking at it, but it's just contributed so much to evidence-based practice, evidence-based policy making, targeting and interventions so that there's the more positive use of resources, and just understanding health disparities better. There are disparities in quality and completeness of data. It challenges actually accurately capturing and measuring social determinants of health, and these may limit those data-driven initiatives. And unfortunately, sometimes the very people who have the highest need that we really want to serve are the groups that lack the data quality and completeness that we want to see. This ends video 3. Thank you. I know this has been a lot of information this week, but I hope you have a good week, and please, as always, contact me if you need anything.